All right, good afternoon, ladies and gentlemen. My apologies for being late. I hope that you enjoyed lunch. I hear it was fantastic. No, but it smells good. Call this meeting of the October 26th Governance Committee meeting to order. And first up, are any citizens wishing to address the committee? None. Okay, none. Seeing none, approval of the minutes from our August 24th meeting. Those were available to you on the portal as well as your information. I'll entertain a motion.
Second.
Second. Okay, motion by Steve Montgomery and second by Ms. DeBose. All in favor? Aye. Any opposed? Thank you. I'll forgo the committee chair report other than to say the Northeast Clinic is moving along quite nicely. Lots of dirt being turned over there, so that's really good news.
Go by that frequently.
All the time. We'll move on. We'll call up Ron and his team for the ERM update.
Good afternoon. Well, today, as always, on my ERM update, I always get a little help from my friends, and so that's right. Exactly. Exactly. Next time we'll cue the music. But before we do that, let me get my slide going. We have 3 updates to give today during our ERM portion of the meeting. Just wanted to give you, before we get into these, I want to give you just an overall status of where we are with the program as a whole. As you know, over the last several months, we've come at these meetings and presented each of the top 10 so far, and we have now completed 7 of those, and we have 3 remaining. Authority and accountability, which is more in the people pillar. Operational excellence, which deals with how we execute against our plan and strategies under stewardship, and then we have strategic partnerships in terms of what are our strategic partnerships that align with our organizational goals. But today we are going to hear from the executive risk owners from 3 areas: academic programs, behavioral health, and primary care delivery, which all are, as you all know, are very integral to our goals as JPS and as a network. The other thing I would say before I bring them up is that where we are as an overall ERM program strategy is phase 1. We're in phase 3 now of this program. Phase 1 was the risk assessment, identifying organizational structures, right when I started about 2 years ago, and setting up this reporting process to the governance committee. Phase 2 is where we are almost done with now, and going through each of these top 10, going through the risk identification process, identifying the top 10. What do these actually mean for JPS? What specifically are we doing to address those? And I think as we talked at the last meeting, one of the things that as we move into phase 3 is to give you as board members updates now that we've given you an overview of what each of these are, what the key risks are, how are we doing against them. And so each of these that have been presented previously will be coming back to you in terms of where we are against our plan around those. And then I'll also will say we will start kind of a re-rationalization process here probably in the late fall. Many of you may remember I met with many of you at the very beginning from a risk conversation. And it's been a couple of years now, so I want to take that back up again, so you'll be getting some invites from me as your schedule permits. Questions on kind of process-wise? I will say I had the pleasure of attending last week the American Society of Healthcare Risk Management Conference, ASHRM, which is a part of AHA, American Hospital Association. And it's my first time attending that one. As you might imagine, healthcare risk managers are a wild and crazy group. They yeah, that's where the fun happens. Yeah. But
So you fit right in.
I fit right. Yeah, exactly. But I did get a number of good insights from an ERM programmatic standpoint that I'll share with you at upcoming meetings that other institutions are doing across the country. So we'll share that as well. So without further delay, I guess one thing in terms of setting standards, you've seen this slide before. This is the risk maturity scale that each of these are rated against in terms of where we are in each of these from a maturity standpoint. And as the risk owners come up, they'll speak a little bit about that. The first one we have is academic programs, and so I'm going to ask Dr. Elliott to come up.
Good afternoon. So excited to kind of talk about this because we're in the process of really defining where we are and where do we want to go. And I think, as you can see in our maturity level, we're in the initial phases of it, and we're looking forward to getting a more defined process and defined metrics as we move forward. I think working with Ron was really great to be able to identify where we are in our risks. I think as we're trying to prepare our trainees for careers of excellence and moving them forward, that's our goal. And we also want to make sure we're recruiting the best and we're retaining them. And I think one of the things we've identified is a bit of our inadequacies around retaining our residents. We have been able to do that somewhat, but we want to be able to understand what our baseline is around our retention rate. So those are some things we're going to be looking at in terms of how do we really train ours and really keep them here at JPS or in Tarrant County and beyond in Texas. And then also, what is it to be defined as a national leader in healthcare research, and how do we redefine and reorganize to be able to accomplish that? So our risk around research compliance, we've started that process in terms of reorganization of our research arm that also impacts how we train our residents and how do we help our faculty and our patients, centered around patient safety and quality. And with our new Office of Clinical Research, our Office of Outcomes Research, it's going to be a critical portion. And also with our new IRB and developing our regional IRB, that's critical in terms of improving our research compliance. We're looking at our engagement of residents. Overall, we've not had as much engagement of our residents in our overall hospital administration. That's a critical portion of our ACGME expectations around a clinical learning environment. And so we are looking forward to having them more engaged in our hospital administration in terms of our hospital committees, and really having them have a higher educational threshold around quality and safety and administration of hospital activities. The learning environment, as we looked at our previous experiences, our facilities and our space, it's always a challenge, as I've come to know as I've been here the last few months. So we're really actively engaged in that because that is something that was identified by the ACGME in prior visits, and as we're looking forward to upcoming visit very soon, we're expecting them to be here for a clinical learning environment review visit anytime now. We have to really actively engage in improving our spaces for our resident facilities and enhancing their well-being around those areas.
Can I ask you what's
Absolutely.
included in those
Yeah.
facilities that they're talking about?
So teaching space, so where our teaching teams are able to round and be able to engage in activities around learning. Do each program, making sure they do have enough space to be able to have conferences and be able to have their didactic and their lectures, and also our call room spaces. And so our resident spaces around being able to have social connections and also for sleeping spaces. So we're actually just had a walkthrough yesterday too, and we're doing some good things around that. I think we're going to be okay. I think the teaching space is probably one of the biggest challenges, just making sure we have consistency around that for all of our programs throughout the hospital. I think as we look over the next few years, we'll be excited to see that be a part of our priorities as we move forward with our space expansion.
Thank you.
Yeah. And then inability to retain, we've just talked about that. So the first thing we need to do is really kind of understand what our baseline is. So I've been able to obtain some data around our current acclaimed physicians as far as JPS grads. So what we're trying to do, believe it or not, is not as easy to be able to obtain that data, to even know where you are in Tarrant County and to know where you are in the DFW and in the state. But that's our goal this year, is to really obtain our baseline data of where we are and where our grads are. We've started a process already this year to be able to say, hey, as you're going forward, let us know where you are. So we're going to be able to track that from here on out. And then the alignment of safety and quality, ensuring that our educational initiatives, all of our curricula, are aligned around the organizational goals of patient safety and quality. So we have started some processes around that, which we're excited. So I think as you look at the strategies, developing our regional IRB, the collaborative environment around CME, as we're working with UNT around that and creating the organization, a program to be able to do some CME for our faculty development and really building that continuum of UME, GME, and CME. The library has been a big win. It's been really well received by all of our faculty and residents, and we're continuing that work with our clinical library, the realignment of research, and working on our scholarly activities around that, and our goals, and really improving our overall productivity around academics and scholarship. So happy to answer any further questions around that. Thank you.
Thank you, appreciate it.
Thanks.
The next area is behavioral health, so I'll ask Wayne and Dr. Podowitz to come up.
Good afternoon. So to provide a bit of an overview of the behavioral health risk review, the top risks, and some of these we've even talked about recently, the environmental safety risk factors, we talked about it the last, not this couple of hours ago, Finance Committee, but the one previous, about some of those hospital environmental risks that we have to find ways to mitigate and eliminate. We also, some risks around the volume of patients that we serve. There seems to be an ever-increasing demand and need for services, and oftentimes a decreasing pool of individuals to try and fill that space and meet those needs. There's a general, just kind of with the patient population that we serve, there often is a challenge around the patient's actual adherence to treatment. So even if we get them, sometimes we even can get them into the hospital, get them stabilized, and then as they discharge and return to the community for a variety of reasons, sometimes they will struggle with adhering to what those treatment recommendations are and following through with that. Sometimes those are intentional choices that they make, and sometimes they are kind of circumstances that kind of form around them and contribute to that lack of adherence. And then there's workforce challenges. So there's a report that came out a couple of years ago. In 2015, I think 25% of the psychiatrists in our state were over the age of 65. And so we have an aging workforce without enough volume, without enough training slots to bring professional staff into that. And as other systems have begun to try and respond to the behavioral health needs in their communities, that's only created a bigger challenge when it comes to workforce and labor.
And Alan Podowitz is not part of that statistic, correct?
No, not at all. No, absolutely.
I've been told that I'm not.
And so there's probably not adequate, sufficient numbers, probably not adequate or sufficient training programs. There's not adequate or sufficient numbers going into some of those programs. And then the general aging workforce in general are all kind of contributing to what is kind of a set of dynamics that create some interesting situations for a lot of systems. We are somewhat more fortunate than a lot of systems because of the residency, because of the work that our providers do to train and oftentimes retain our residents. It has not created the same kind of dynamic that they have in others. There are some states that you literally could count the number of child and adolescent psychiatrists on one hand in some states. And so we have not had that kind of burden, although child and adolescence is one of our challenges. I think we have gone as long as a year or more with an opening for child and adolescent psychiatrists trying to recruit them. So, and I do know that in Texas in general, if you wanted to get Texas up to the same level of psychiatrists per 100,000 as the rest of the country, you would have to take every psychiatry resident that finishes residency this year, and they would all have to relocate to Texas in order to bring us up to where the national average is right now in terms of psychiatrists per 100,000. Yeah. So it's a pretty remarkable gap that we face. Then also the incorrectly assessing patients, and I want to be sensitive to that. The way I wrote it was, and edited it probably wasn't very clear, but it isn't quality of care by the physicians. It is the challenges that inherently come with a population who oftentimes are not being straightforward with you about how they're presenting, whether that be intentional on their part, which oftentimes it is. They have some plan or desire, and they want to convince you that that's not what they're wanting to do or what's going to happen, so that you won't intervene in that. Or sometimes they're so confused they don't even recognize the challenges that they're dealing with. And so as they give, psychiatry is interesting. They're almost put in a position where they are forced to kind of, there's an expectation that somehow they can predict the future. I mean, they have great insight into the mind and into psyche, but they don't have the ability to predict what's going to happen. But yet there's almost kind of an expectation of that. And so that's really what that number 5 is speaking to, is that inability at times to be able to correctly assess because of the lack of information, the misinformation, whether intentional or unintentional, and just the dynamic of it. So I think we all recognize how quickly even our moods might shift in a day, how quickly we can go from having a great day to a day that's challenging and we're frustrated and perhaps not at the top of our game. And you add the complexity of the illnesses that our patients have, and they can be relatively positive as they're leaving, and then a few days later, things can be very different. And our patients tend to have circumstances that do change rapidly and disproportionately impact them in some very challenging ways. And so I think that piece of it also contributes to the challenge. As you look at some of the risk mitigation strategies, we are in process of developing kind of an innovative behavioral health model where we figure out how to leverage our behavioral health resources across a broader part of the district. Part of that is being driven by the 1115 waiver and the new measure bundles that are coming out with that, so that we can, we're not going to be able to just focus on people with behavioral health conditions who admitted to Trinity Springs or who show up in a behavioral health clinic. We're going to have to look at depression remission across everybody in the health system that has depression and what that looks like on a broad population base. So we've got to figure out how to do that. It is kind of blending the best practices that are in a few different models into one that we think will work nicely here in our system. Also, the outside medical services contracts, while the expense is a challenge, they are part of the strategy and being able to mitigate the volume piece that we have. When we got more patients than we can adequately serve on an inpatient basis, trying to find beds adequate to meet those needs, and those contracts are a part of that strategy. A transition management program, you'll probably see a publication come out pretty soon from that. We've got a transition management program where it engages people post-discharge to help reduce the likelihood they come back to the hospital within 30 days. And that program has reduced the likelihood of readmission by over 50% for the patients that we serve here. The implementation of a measurement-based care model. Yes, sir.
Is the neurostimulation?
So the neurostimulation program is really a combination of ECT as well as TMS. And so ECT is electroconvulsive therapy, which people are probably familiar with. TMS is a similar concept, but much less invasive. TMS is applying an electrical current through a magnetic piece that's spinning to impact the brain and kind of reboot it a little bit, if you will. It doesn't have to be done under general anesthesia. No, it does not. ECT does, but TMS does not. It's done in office settings, and it has a pretty decent efficacy. I mean, it really has made some impact for people. And ECT generally, because of the anesthesia piece and the side effects of memory loss and all that, it tends to be a very last resort kind of treatment. Like everything else has failed and the doc's done everything. He says, I think this is our best shot. And it's great treatment for those who are treatment resistant and struggling. TMS, because it doesn't have those side effects, is significantly, you don't have to wait until perhaps they've gotten into such a dire position to be able to recommend that.
Patients with what diagnosis?
Depression. So for transcranial magnetic stimulation, this is the TMS. They would be treatment resistant, and the typical threshold right now is that they fail 2 complete medication regimens, and they can become treatment resistant. There's 2 arms to that we don't have, which I believe that Mr. Young will talk about in a minute. We don't have enough therapists to do the therapy along with the medication, which is proven to be the best treatment method. But with the transcranial, it's a treatment-resistant depression. It's not been found to. There's not been enough research into bipolar depressive disorders or schizoaffective, where you have schizophrenia and depression. So we don't know the utility in that. But with the depressive disorders, by the time that a person with depression comes into our system, they've pretty much met the treatment resistant, because they've drifted down within society enough that they require JPS services. So hopefully we can get them healthy and back up the chain.
And so we're in the process of implementing a measurement-based care model, which is, I think it's not foreign to most of us. If you have hypertension, you go to the doctor and he measures your hypertension, measures your blood pressure, and then documents it. And then over time, you might go in and he might say, well, this has been high 3 times out of the last 4 visits. Maybe we need to look at that. And psychiatry has not had those kinds of, there's still not certainly lab values and those kinds of things that are objective. But at least creating evidence, utilizing evidence-based tools to create assessments at point in time of the patient's perception of their care, not their care, but their situation and their wellness and how they're doing, and be able to track that over time so that as you see journal increases and declines, and there's some pretty decent evidence that it's a much more effective process than saying to the patient, how have you been doing since we last visited, or how's it going since you last were here? They tend to kind of respond and react to whatever's got their attention at the moment, as opposed to an evidence-based tool that kind of walks them through a little bit more thorough of a perspective on how they're doing. And then final is the credentialing of master's level clinicians. You'll see in the near future a request to change the medical staff bylaws to be able to allow the credentialing of those master's level folks, which will also open the door for us to be able to get them included in our managed care contract so that we can bill for some of the services that our master's level clinicians are doing. And it's one of the challenges why there's not quite as many as we'd like to have, is because we don't have the infrastructure needed to be able to adequately bill for those services. And they're not robust, but they probably get close to paying for themselves. It's not making money off for anybody, but it will probably negate the expense associated with delivering the care, at least if we can do it in a real way. And so I think that's all of the prepared comments. Certainly, Dr. Potterwoods are happy to answer any other questions you might have.
I just have a question on the innovative behavioral health models. Is one of those models looking at opium addiction, since that's been to be declared as a national health issue? Is that one of ours?
So it is not one of the innovative pieces of that model. It is an area of focus, obviously, nationally, trying to figure out how to impact that.
Right.
The American Hospital Association just came out this week with opiate guidelines, prescribing guidelines for health systems to be able to look at it, figure out how to incorporate that.
Okay.
And I'm certain that our physician leaders will be looking at that and how they manage that from the care processes that are going on here. But the model is really about how do we blend virtual and telebehavioral health. How do you do telebehavioral health coaching and not just care delivery, as well as traditional telepsychiatry, as well as our face-to-face model and footprint that we have, into something that's comprehensive.
Directly into primary care settings so that you don't have to move patients to a lot of different places, that it's really pretty viable.
All right. Would that be a concept that you could use for, as I'm working with schools and we have school-based clinics with some adolescent that's having behavior issues, would that be a program that we would be looking at?
It is. I think that's probably a phase 2 to this, but to think about how we might support our school-based clinics with a virtual kind of behavioral health team that could be available, because we've tried doing it where people are in there, and it's kind of hard from a resource perspective because they're so scattered, and not all those youth need our services, but to be able to be available when they do need us, particularly as a backup to the providers that are in those clinics.
All right. Thank you.
Yes, ma'am.
Anybody have anything else? Thank you all very much.
Thank you. Appreciate it.
Appreciate it, guys. Thank you. Yeah. Before I bring up primary care delivery, I failed to mention at the beginning, I know you all know this, but for those that are watching at home, so to speak, risks. Huh? The two people. Risk. When we say risk on these slides, these are meant to be termed as negative statements, not necessarily statements of fact in terms of this is what the reality is. This risk management as a whole is a discipline around having a thoughtful process about identifying risks that could impact what we're to do. So I know I've reiterated that before, but for those that are outside watching. So
your comment basically is you're gonna look at worst case scenarios.
right.
And then you started your presentation by telling us that you went to a convention of people that look at worst case scenarios, and you spent 3 quality days with them.
Absolutely, yeah, and
Just get
that
the
was
record
value
straight.
added. It was. So with that segue, I'll bring up Dr. Duncan and Dr. C.
He never brought up that segue until you guys were coming up, so.
Good afternoon. So I'd like to introduce myself and Dr. Shakuri. We're actually new leaders, and so we're actually not giving you an update we're giving you an update around primary care delivery risk, although for us it really is our first time to really talk about where we see primary care and where the risk is around access for that. I'm Dr. Duncan, Senior Vice President of Community Health, and partnering with me, I say my partner in crime is Dr. Shakuri, often referred to as Dr. C, and she's our Executive Medical Director for Acclaim. And so this is a great partnership because it really does allow us to begin looking at this as more as a team-based care model for primary care. And so it's been great having Dr. Shakuri here at JPS. And for me to really have this opportunity to be over a very large part of JPS, the community, I really do see the importance of that. In fact, it's my goal really to put the hospital out of business. No, I'm just kidding. But I do see that the country is really looking at, it's not just JPS, but the country really does look at, there is a risk around whether we are going to have enough community and ambulatory settings to be able to provide the care that will be taken care of. We'll be closer to the patient in the care that we give in the primary care setting. So I see this risk for primary care delivery really is a risk of a hospital who does not look at primary care differently. I first of all, I want to thank Ms. DeBose for having met with Dr. Shakuri and myself this week and kind of give some background on JPS and to speak a little bit about just primary care. But today she shared that she had called to get an appointment for herself. She was told that her provider was retired or no longer there. So when she was given an appointment, she was actually given an appointment over 30 days, is that correct?
Oh, way over 30
Over 30 days. However, we measure our next available.
No, just regular.
Over 30 days, right, but yet we measure kind of a very generic, if we look at what the board metric is really around can we do most of our primary care appointments in less than 25 days. And the danger that we sometimes run with that is that we're not really providing the right care at the right place at the right time. And so how do we begin to move towards that? And so we have to look at it a little in a different lens, with a different lens. We have to really begin looking at who is our community and how is it that we begin to build that primary care delivery system for the communities that we are serving, and what are the different services that we need to have at each of those sites. So with that said, the risk that we have for this are basically the same risks that we heard with behavioral health. That is around, do we have the right skill? And will we be able to recruit the right skill? The number of providers, how is it that we are going to be able to provide the number of providers, both in specialty and primary care, to see the demand that will be here in Tarrant County alone with growth? And then that population will be a little bit older, so will we have enough of geriatric care, enough of that specialty care? A lot of the risks, as I said, are the same that we heard with behavioral health. The other thing I want to say before I turn it over to Dr. Shakuri, because her expertise really is in population health, is that we have to understand that primary care does not sit by itself, and that it really is a service that has to begin integrating with other services within the hospitals. So with inpatient care, we have to understand that when our patients are hospitalized, how is it that we now transition and have that communication with our primary care settings, with our specialty settings? So transitions of care become really important. And so although we are the two that are sitting up here, we work with a much larger team in order to be able to begin to look at and to begin to tackle the primary care delivery needs. And so with that, I'm going to turn it over to Dr. Shakuri to talk a little bit about her vision. We are doing a lot of work. As new leaders, we are really, really busy. And we understand that there has to be a new structure, that there has to be different people, and that we have to leverage our IT, and that we have to be able to use our technology to get closer to our patients. Many of us use FaceTime with our family members. We would love to get to that point where we're using FaceTime with our patients. That's going to take working with our IT team and understanding the HIPAA around that, but also being able to provide those things that they take for granted and that they use in their everyday lives. So with that, Dr. Shakur.
Thank you, Dr. Duncan. Good afternoon, everyone. Thank you so much for this opportunity. We are so glad to be here and actually share what we are doing. And like Dr. Duncan said, we both came in I came in about 5 weeks back. Dr. Duncan came in about 6 months back. So we are the work is in progress. We do realize that there are some challenges, there are some opportunities for improvement. The great thing though, we are in this great organization where we have the leadership alignment and we have great teams. We are working together. One of the things, my passion and the organization's passion is value-driven population health. That's one thing we are definitely focusing on. Like Dr. Duncan mentioned, is the right service at the right time to the right population by the right person. So when I say that we are working with our medical directors at the local clinics very closely to make sure that we have the right person at the right time that community needs based on the community clinical services or any other service that the community needs or based on the hours that community can come to the clinic. So there is a lot of work going on at the local level from the template standpoint, from building that relationship between the medical directors and the practice managers, looking at the management. Having said that, I'm also very passionate about the physician wellness. There are some studies that are already published. There is a lot of work right now going on that shows a relationship between the physician burnout and low quality. So we are from physician group standpoint, we focus very closely on this, and we are trying to provide some resources to our physicians to make sure that they have that support that is necessary from a physician standpoint. Most of the time the physicians are in this unique position both at the individual level, at the work environment level, and external factors that are affecting their work environment. So we are looking at all those three factors to make sure that our physicians are happy, which will in turn reflect on our patient satisfaction, of course. So that's definitely one thing. The third thing we are looking at is the ratio, like Dr. Duncan mentioned, is a nationwide problem, the primary care access. But that goes hand in hand with the availability of physicians. The primary care physicians coming down the pipeline is much less than what our demand is. And that goes along with our GME programs that need to be more out there. And so having said that, what we are looking at is what kind of ratio we can maintain, again, taking the community needs into consideration for our population, physician versus APP ratios. There are wonderful nurse practitioners out there, so we are looking at that. We are doing a mix based on the community needs, based on the population needs. So that's another factor we are looking from physician standpoint.
So we look forward to really coming back to you with all the work that we will continue doing, the excitement that we really have in the ambulatory setting, and continue to give updates is how we are building that. Appreciate your support with that. Any questions that we could?
I'm really interested in your FaceTime with your physician thing, and I've also see that the integrated communication platform or the phone system optimization. Ron and I were talking with Michelle last week or 2 weeks ago. Is there any kind of text response or to cell phones that might be able to help better connect us or physicians to their patients, or to at least send them to MyChart so that they can actually know that this is their portal, this is where they can find their stuff?
Yeah, so the technology, if you ask, is the technology there? I mean, I know for my dentist appointment, I'll get a text and you kind of push a button saying, I'll be there or not. So the technology is there. We do have to work through those legal and those HIPAA in order to do that. We also have to have that permission from the patient, but we really are looking for alternative ways to mail and to telephone calls that we know most of our population, including our population, no longer really use and are becoming irrelevant.
Right.
So there is that opportunity, and we will be looking at that. Pushing to MyChart, and we did send a couple of our community health kind of EPIC experts to the most recent EPIC conference, and I basically said, listen, I need for you to get into those MyChart, work groups and conferences and come back to us about what MyChart is going to be able to do and how we're going to be able to leverage that in many ways, from lab reporting to communication with the doctor. I mean, there's so much that can be done. And so we're looking forward to that, and we have some strategy that's beginning to be built around that. But we really do have to leverage our IT.
Anybody else?
May I make just a quick comment? We've Robert and company heard this before. I think that the clinics and primary care are really the more important aspect of JPS than just the hospital.
Thank you very much for that.
I really think that is the direction we need to go. I hope that we're wise enough to provide the resources that you need to accomplish what you need to do. And I'm looking forward to it. You guys are guys.
That's okay.
Incredibly,
They got it.
incredibly important.
They got it.
Well, the two ladies that you see before you are incredibly talented people, and they bring a great deal of expertise to the equation. We constantly try to figure out how to provide best performance and best practices from an ambulatory care and a clinical care standpoint. And we have, I don't want to say we've missed that boat, it's just a deep, hard challenge. And when I talk to my colleagues in the nation, many of them are facing some of the same problems. I don't want y'all to think this is, whoa, JPS, we're behind. It doesn't make me feel any better that you can't get an appointment within 30 days. It makes me feel terrible. Or whatever the situation is, or whatever our problem is, or just merely access.
I think we were saying in a good way, actually, but.
Yeah, I understand, but still,
Yeah.
that should be even reduced. I mean, I don't want to take excitement by the fact that you're out that far.
Right.
I want to be even better. But we've made some pretty big progress on an organization that never saw itself as being integrated. And I think what you're going to hear and see a whole lot more about in the future is the integrated model of JPS. And until we do that, we're going to continue to see challenges that we can't afford and we can't provide to the community, such as, I was on a panel yesterday with 8 of the CEOs, 7 other CEOs from Tarrant County, and almost every one of them were happily talking about the expansions to their programs and expansions not only to acute care but to emergency room. That's a model to me that would prove that the earth is flat, because at some point you're going to fall off that.
Right.
You can't keep building $50 million, $80 million, $120 million expansions to your ED. You have to figure out the best way to decompress it. And the best way to decompress, and the overall answer to America's healthcare problems, is a stronger primary care system. So I think we have the opportunity here with some really bright people to be making headway in a pretty dense jungle.
And I think it's really taking a look at our current resource and saying, can we take what we have and shift it to where it is that we need to move that same resource? So do we need as much of this kind of FTE? Could we really look at this and say, hey, there's a different skill set that's going to be needed moving forward in primary care? So many times you can do it without really coming forward to the board and asking for additional monies in order to do it, but really taking that resource, a bucket that you have, and being able to reallocate it or repurpose it in the right way into the right place. So
I would just like to add that the time that I spent with Dr. Duncan and Dr. C was very exciting. I got excited about what they are planning on doing, and I think that given the time and what they're going to do, our ambulatory area, which I think have been moving in the right direction, will really get where we want it to be. And that I'm hoping that they will be able to maybe come to quality and really delve into the stuff that they are doing, because it is exciting. And I want to clarify something that Dr. Duncan was trying to say. the appointment that she was saying was over 30 days, wasn't in our system. That's with another healthcare system. So what I was trying to say is that sometimes we are punishing or saying we're not doing a good job, but when you look at what's going on in the real world, it isn't 30 days for new patients, it's longer. So that was what we were trying to say, but
Super.
I'm really excited that you two ladies are here, and
Thank you
I
for your
think you're,
support.
with what your plans that you shared with me, that it's exciting.
Thank you. Thank you very much for your support.
Primary care is not just family practice.
Right.
Mm-mm.
Primary care is nurse practitioners,
Right.
physician assistants.
Mhm.
One thing that is missing in Tarrant County is there's not a bona fide, strong internal medicine
Mhm.
residency program. And once again, most residencies, you tend to keep your best residents. But we do not have that available at the current time. Internal medicine residency is also a way to dovetail into things like nephrologists, neurologists, those physicians, I call them neurologists, those physicians that are very difficult to recruit. The claim is still trying to recruit a neurologist, for example. The second thing is the term best practices is used a lot. Best practices frequently are just a result of sort of a committee of physicians, nurses, et cetera, deciding on what may be the better thing to do today. Best practices can turn overnight, especially with technology, medications, and so whenever we say best practices here, I'd like to make sure that we're
Defining it?
defining exactly what we
Sure.
want. That was not meant to
No,
be mean to you.
not at all, not at all. I think,
mean
Quit being mean.
no.
There will be no meanness.
Tough
Mr. Chairman?
I just want to say one thing, and Robert won't brag on himself, I'm going to brag a little bit, but I happened to be at the meeting yesterday morning, it's a full house. There were 8 other CEOs there, I heard all their presentations. We all know those individuals. Both medical schools were represented. A cross-section of Fort Worth business people. But, you know, Robert, your comments were about our patients, and really sitting here, having heard Dr. Duncan and Dr. C, under their leadership, we're really excited because everybody kept talking about integration, their other systems. They kept talking about their new buildings or their new, this is what JPS really is. And I think we're going to the field with our patients. And, you know, we found that out through the Blue Ribbon panel. We found that out internally long before someone mentioned that. So I want to say your comments, I was very proud to leave the room wearing a JPS button yesterday morning. And again, know every one of those gentlemen personally, but it was just great to hear about JPS. You spoke from the heart. I saw a lot of slides, and we're building this, we're building that. We're the best of this, we're the best of that. We talked about patient care, and that falls right into exactly the new leadership we have with y'all in that. So Rhonda, the team, I say thank you very much. But you did a very good job yesterday,
You're kind.
Robert.
Thank you very
But
much.
once again, we're the only organization that is public. We're on television all the time, Barbara's speaking all the time, Charlie's in meetings all the time. The other hospitals and their CEOs are not doing that. They're not, you don't get to see their face.
DT?
Question on the, I know you knew that this, we have a few initiatives, in terms of rollout and all that stuff, I know for patient engagement and all that stuff. Can you come back and educate us a little bit of when do you use MyChart, when you use Healthy Connect, Healthy Planet, and when do you use Emmy?
Uh-huh.
And do
In
you
fact, we
have
just had
enough there?
conversation recently about it,
Because I know
yes.
you guys purchase Emmy also as well,
Right.
so when do you actually?
What's
have
the
it-
endpoint you're looking for, DT?
It's the rollout, the supporting software.
How we're
tools
using some of
to
that.
use to manage those patient engagement. Because it's a two-way street also as well. just to get compliance and keeping track of them and make them participate more.
No.
Because I don't think you guys look at some other new stuff like HealthLink Navigator,
Mhm.
and then also Conversa and all that stuff. That may be something that might be helpful in recording that together. But we do have so many hard software.
We do have a lot of, yeah,
software.
yeah.
Which is your strategy going forward?
We will be glad to do that.
Yes. And that's exactly what we are looking at right now. We have so many resources in our organization, even internally. So we want to make sure, one, utilizing the existing resources efficiently, of course, but also streamlining those resources, because some of those resources, maybe our community, our patient requires either a different resource or not that resource, but a different existing resource that we have. So we are definitely looking at that, and one of that is technology, like you just now mentioned. So we are going to look at that and get you more information.
Let me tell you, in my opinion, the challenge. You can't have universal access, little cost, and quality. You hardly ever get all three. Something has to give. I think that is trying to get all three together, you folks are on the right path, and with the limited resources that we can supply, you'll do a good job. And I honestly believe you'll have great quality of care. You do not have to provide universal access, but we do have a patient population that we are challenged to see. And I think that with Sharon's stewardship and Bill and Robert, the resources will be available to make them succeed. That's probably why
No, that's helpful.
Well, you can-
I think that the My Chart is one of our tools that I think if we educate more, it's being used, but that's a great tool to have My Charts. And I don't know if any of you have taken the time to look at it, but that's a way that if they continue to develop that you could send messages to the patients to remind them of their appointments. They could go into that, answer. You can order your medicines. You can send information to your doctor. It's a great tool, and as more and more of our patients start using it, I think that's one of those areas that if we work on that, that will be a great asset to what we're trying to do. That would help with the integration, because you have all the information on your inpatient stay. It's amazing what you can get. I mean, I love it. Okay.
I thought I would hear more from DT about population health.
Well, it's an abuse word. That's why I don't use it,
Yeah,
because it's more of utilization. It's more of
What word would you use?
it's performance
Perform.
measure,
outcomes,
performance,
having, yeah,
and outreach.
outcome, yeah,
Because it's hitting targeted audience.
yeah,
That way, you don't talk about projection. You talk about reality.
Okay.
yeah. I think it's really about,
Just so I know what you're thinking.
yeah.
They had a good start. We
I-
have tools. We just need to consolidate,
Yeah.
see which ones.
Yeah.
I know they have Emmy, right? Before Emmy, it has educational track and all that stuff
Right.
that goes with it. My chart have it too.
Right.
But then when you look at, you have to see which ones is easier to use
Yeah.
so that you can get the participation up, because no hospital has more than 6%
Right,
of the people using it, and you maintain a very expensive connection.
exactly,
And then there's some sort of disconnect behind the scene between the care manager, the provider, and also IT, because we all don't know where we're going. Nobody have a roadmap, so there's a lot of to be released in 2-3 years, and it got pushed out.
Yeah.
So at what point do you say, so what, let's get something that we can address today,
Sure.
so that we can get our workforce lined up.
Yeah.
And that's why
Yeah.
I'm going through certain software and see what's the reaction and how do you guys apply it, and how do you gain traction from it. And it's also the importance of the education from the patient, and also
Yeah.
See, there's lots of interest in this committee.
Yeah.
In what you're doing, and not only.
And we could
interest-
talk all day.
Yeah,
I'm
not
really gonna
only-
be
not
honest
only
with
interest,
you
but
about
A lot of
this.
excitement from Dr. Duncan and Dr. Shakuri. Thank you very much.
Ron, stand up and just say, shut up.
I wouldn't do that. I'll be breaking the third rule.
Thank you all very much.
Thank you very much.
All right,
Thank
thank you.
you.
Appreciate it, guys.
Third rule violation. He's on it.
We'll move on to district policies, but I'll also point out to the committee that Michelle doesn't have any reports for us this week.
There is a
Oh, we've got
brief-
compliance to do,
yeah,
sorry.
yeah.
Before we go to compliance.
Really?
Michelle doesn't have a report for us this week, but she promises us that I believe the February meeting is going to be quite lengthy and in detail, so
Okay.
be on time
that month.
and be
Okay.
ready to pay attention. Ron, take us for compliance.
And it'll be on the internet.
I pointed to me.
Okay.
We thought we would give you a little bit of a break this meeting, because there's not a lot on the compliance side yet either. We have 2 reports that aren't ready for this meeting, but will be also for next meeting. So it'll be a fun and exciting next meeting in February of 2018. But I did want to share a couple things with you in terms of key headlines. And I know some of you really like some of these headlines, and I know that they're the misfortunes of others. But one of the reasons, and I wanted to bring this to your attention, one of the reasons I select certain of these headlines is that these are some of the focus areas in our compliance work plan that we're going to be focusing on in 2018. And some of them have regional interests, like this first one, this Dallas doctor who was sentenced to 35 years in prison for a fraud scheme for Medicare Medicaid fraud. This is probably one of the stiffest fines on a physician that was brought by the Department of Justice, and it was a conspiracy, and they committed $357 million fraud for unnecessary home health care services. This physician was, over a period of years, essentially had various entities that he owned or controlled that certified Medicare patients for home health care that were not eligible otherwise for home health care, and they billed for those services inappropriately and received reimbursement from Medicare around that over the period of years to the tune of $357 million. And he has to pay personally $268 million because he was the primary person that was a part of this conspiracy theory or conspiracy scheme. Mainly brought this one up because it has obviously a local DFW interest, but also just the continued importance of our coding and billing program in terms of the importance of ensuring that.
You're gonna keep us off the headlines, is that what you're
Oh,
saying?
that's my number one goal, yes, absolutely. You're right, it didn't say Fort Worth, that's right. The next one is around anesthesia. There was I'm sorry.
May I
Yeah.
comment on this one?
Yes.
Doctors, I have had personal experience the last 6 months with my wife's mother being in the hospital, repair of her broken femur, and put in a nursing home. I've had to deal with these companies and getting permission. It's a difficult thing to figure out the pathway that you got to get these things. And it's very easy for me to see how a doctor could work into this and cheat it, so to speak. That's a very easy for me to see, having my personal experience.
Oh, absolutely, and it's a very vulnerable population
Yeah.
also, and it's a shame because it takes money away from folks that rightly deserve it.
Just to add some good to say, we brought my mother-in-law home, and she's able to take care of herself except for a few things.
Oh, that's great. That's great. That is good news.
I have to feed her. We had some home health for a while. We had some home health for a while, but that was a problem, figuring out what she was eligible for.
That's
So
great.
finally, we just
I get calls to see if I need a motor.
decided to hire my granddaughter to come in and give her a shower twice a week.
That's great. But no, that speaks to the point. This is a very vulnerable population. This is an area that the Department of Justice and OIG is focusing on. It has for the number of years for that same reason, that home health has been an area of unfortunate fraud. This next case is actually a little further out. It's in New York. It's in the Syracuse area. There's an anesthesia practice that essentially an upcoding scheme that they, for anesthesia services, and made a settlement to resolve a $2 million payment. What they were doing in this case was they were using moderate sedation, and under Medicare guidelines, in order to bill for moderate sedation, you have to have at least 16 minutes face-to-face interaction with a physician. This particular anesthesia practice had less than 16 minutes, and they were still billing for the moderate sedation service. Even after being audited, even after being told by commercial payers that those claims were denied, they continued that practice. And so the Northern District of New York Department of Justice imposed this penalty on them because it was a long-standing practice. And essentially, it was improper coding, and they knew it was improper coding. The reason why I brought this case as a part of the headline is that anesthesia is going to be an area that we're going to be looking at in 2018 for our coding and billing review a little later in this year, so you'll be hearing kind of more from us a little bit later in this area. And then the last case is Carolina's Healthcare. I know two of our executives came from that institution, but no attribution, but it's a great place, but they were hit with a $6.5 million False Claims Act settlement, essentially for upcoding, and they were upcoding claims for urine drug tests. And so, and it seems like it's a small dollar amount, but with the volume that they had over their health system, it added up to a fairly large amount. And so they were billing for these urine drug tests at a higher payment than allowed for these tests. They were billing them as moderate complexity. They were billing them as high complexity when they should have been moderate complexity. And essentially, they were getting what amounted to about $80 more per test by billing them as high complexity versus moderate complexity. And with the volume, it just kind of added up. This case actually was brought to light from a whistleblower. The former lab director at CHS went to the government and basically filed a QI-TAM suit against CHS and said that they were engaging in this practice. The government took up the case, and with a whistleblower case, the whistleblower actually is eligible to receive a portion of the settlement for bringing it to the government if the government takes up the case. And so Mr. McGuire, who was the QI-TAM in this case, received $1.3 million from the settlement for bringing this to the government's attention. And so, again, the whistleblower cases, they are probably one of the most relevant, the most frequent reasons why many of these cases are brought to light. And one of the things, from a compliance standpoint, I'll speak to this, is that in my experience is that oftentimes you can bypass this type of thing by listening to your employees, taking their complaints seriously, and even if there's no basis for them, at least showing that you looked into the matter, showing that the internal processes worked. And that's really, as I view it, a purpose of a compliance program. So we obviously looked at this case because I know lab is an area that we're continuing to look at some coding and billing areas. So there are many others, but I wanted to stop there. I didn't want to depress anybody in today's meeting, but just as a small example of kind of this is still a very serious issue. The government is still very attuned in looking at these cases, and many times they are bringing them as false claims cases if they're upcoding or improper coding cases.
Hasn't Medicare said that there are $1 billion in waste and fraud?
I would imagine at a minimum.
Yeah,
They
it
would
would
have
be
to
small.
find a few trillion,
Yeah,
so.
that sounds low.
But as long as you see the anesthesiologist for 16 minutes, it's fine.
Yeah, you don't want to be looking at your anesthesia.
Something's wrong.
Your watch.
All right, before we get too crazy, Ron, take us away.
The last couple of items, just a coding and billing initiative updates. We recently issued an RFP along with Revenue Cycle, Katie Rutherford's group, to get some software that Revenue Cycle had already been using, but compliance is now going to use to develop a coding and billing dashboard. It's a new initiative for us, so that oftentimes what we bring to you in these meetings are the results of our discrete audits that we have. We have an audit of a specific area, and we share with you our findings. What we hope to be able to do with this dashboard is be able to show trending overall. So, audits are point-in-time evaluations, but this will show a little bit more of a trend overall in terms of key areas of emphasis and that may have or historically may have had coding challenges, whether it be from government actions or from historical JPS experience. And so we think this will be a better kind of a strategic view of the coding and billing area and working with, we have a good partnership with Revenue Cycle in developing this. And so just wanted to bring that to your attention. That's one of the things that for 2018 that we're working on, to have a little bit more of a holistic view of this issue.
We have that software now.
We're in the, it's gone through contracting. The software is called HBI. And so we've used it in prior years in Revenue Cycle. We just haven't used it for this purpose and from a compliance standpoint.
Can I make a suggestion?
Yes.
You may want to get an inventory of what they call a form locator fix
Form locator fix.
inside the billing system, because there are times they hard code at the end, and over time people don't pay attention to it and can get us in trouble. I think that's what got Memorial Hermann in trouble with the lab and all that stuff. So
Okay.
ask for those so you can have it in your hand.
Okay. No, that's a good suggestion. I appreciate that. Okay.
Hard code to get to the payment system from the whole system. So if the software vendor hard coded in, over time people don't keep track of that, it's still shooting out, even though you see one thing, it coming out differently when you go to the insurance for payment. We just need to get our hands on it so that we know which one's hard code. And so when we collapse it back into Epic if we need to for rules-based type thing.
That's good. And then lastly, we, for the first time, I believe, our compliance department participated in the JPS Quality Fair, and we actually placed in 2 of our entries. One of them was related around policies and procedures, so Arena and team, I believe, got second place in the Quality Fair around how we can better utilize policy tech, our policy management system, to do attestations of compliance around policies and kind of new capabilities around that. And the second one, I think we got 3rd place in the quality under compliance related to coding. And so we did if y'all recall, last year, I believe we did a extensive modifier coding review, modifier 25, modifier 59, and so forth. And so our team, along with Madura's team and HIM, collaborated on kind of leading practices on how to properly apply modifiers, and not just from a coding standpoint, but looking at the whole process. And so that won 3rd place. So I congratulate the team for that and taking the initiative to do that. So that's all I have for a compliance report today.
You're still up for 2 policies for consideration,
Yes.
and we will have to take these individually.
Yes. So the first policy is LD 8100. It's the general consent policy. The general consent it went through a very extensive vetting process internally through the various committees, including a legal review, and it basically revised the general consent itself and the associated general consent form and policies. And so that policy, the clean version and the red line version should be in your packet. That shows the changes, as well as the associated general consent form, the new that was edited as well. Neil, I don't know if you want to add anything.
I want to comment. One of the substantive things that came out of this last legislative session were some additional issues that had to be addressed with general consent. Those are now incorporated.
Any questions?
Yeah, what were they, Neil?
I've got another lawyer that dealt with this, but I do know changes. They are reflected in the red line.
Okay, I did not look at these ahead of time. I apologize.
Anybody have any questions? I'll entertain a motion.
Move approval of the general consent policy.
Motion by Ms. DeBose, a second. Steve Montgomery with a second. All in favor? Aye. Any opposed? Thank you.
Okay. Thank you. The last policy is LD 9000. This is internal audit scope and independence policy. This is just, there's a few minor changes to this, nothing substantive. This is just up for its review period, essentially. You can see in your packet the red lines that mainly are more clarifications. There's really no substantive changes to this document. But what this does, and particularly for Michelle and her team, is it helps articulate what the responsibility of internal audit is. Because many times people who have never interfaced with internal audit before, well, why do you need this information? Do I need to give it to you? All of those kinds of things. And it helps articulate, that they are representing the district and doing the work that they do. They can point them to this policy, and it's an education, for those folks as well. And it shows that, that internal audit has the support of the board as well.
This one's pretty important. Entertain a motion? DT, second?
A second.
Ms. DeBose, all in favor?
Aye.
Any opposed? All right. It passes.
Pretty clear.
Thank you, Ron. Committee, we'll take just a few seconds. We'll clear the room. We have a short executive session. We promise to keep it quick. I know people need to leave. And then we'll come back. We'll adjourn to executive session at 1:20, what is that?
1:30.
3, 4. Session, we adjourn closed session at 1:07. There being no further business, this committee stands adjourned. 2:07, sorry, 2:07.